My name is Gordon Tapper. I am a former Chief of Section at the United Nations and founder of a humanitarian organization, Give Them a Hand Foundation, and now President of the United African Congress. The United African Congress is part of what we call the Ebola Coalition, of a group of organizations that are planning a mission to DRC, Benin, September, in the next 2 months. Anyway, welcome to the Maisles Theatre in Harlem. This is the 11th edition of Congo Comes to Harlem. And of course, we are one part of the week-long project. I want to thank Nelson Walker, who is a filmmaker, who has made this possible, and his colleague from the Friends of the Congo organization, Maurice Charney. I don't know if he's here, but we do have a representative of Friends of the Congo here, who is Bibi Ndala. She's there, she just stood up. Okay. And I should tell you that the Maisles Theatre here, it is small, but it is quite significant in this Harlem community. It was founded in 2005 by a very prominent filmmaker, Mr. Albert Maisles, and his brother. Albert Maisles was a very famous documentarian, and one of his most notable documentaries that I'm aware of, and maybe Dr. Judy is aware of, but many of you might be a little bit too young for that, is the filming of the movie, of the concert from the Rolling Stones in Altamont, Give Me Shelter. Some of you may have heard of it, others may not have. Anyway, enough of that. I would like to introduce the panelists who are here today. And we have eminent doctors, scientists, psychologists, and administrators who have, in the past, or is presently engaged in the fight against the Ebola outbreak now, or in the DRC, or in other countries previously. They're Dr. Julie Koreansky. She's an internationally known psychologist who is on the faculty of Columbia University's Teachers College, main representative of the International Association of Applied Psychologists at the United Nations. She was a strong advocate for mental health and well-being, included in the UN Agenda 2030 and the Universal Health Coverage Declaration. She has provided psychosocial support in countries like Haiti, Japan, China, USA, and following major disasters. That's when you need the psychosocial support mostly. She's a member of this Ebola Coalition, which you will hear more about during the program. We also have Dr. Lise Alkaina Stevens. She is a visiting postdoctoral research fellow in the anthropology department at Harvard University and a postdoctoral researcher with Anthropologica and the anthropological exploration of vaccine deployment during diseases outbreaks project at the London School of Hygiene and Tropical Medicine. She received her PhD in social anthropology from the University of Cambridge in 2017 and was a foundation Thyssen postdoctoral researcher at the Institut Pasteur and Laboratoire d'Anthropologie Sociale in Paris. She worked extensively in rural Democratic Republic of Congo since 2012, conducting ethnographic research on environmental politics and the social economic repercussions of Ebola epidemics. She has also worked for UNICEF in the immediate aftermath of the Ebola epidemic in Equateur Province, DRC, in 2018. Dr. Mary Choi is a medical officer with CDC's Viral Special Pathogens Branch. She graduated from George Washington University School of Medicine in 1999, completed her residency training in emergency medicine at the University of Michigan. She completed a fellowship in international emergency medicine at Columbia University. We also received her Master of Public Health degree. She graduated from CDC's Epidemic Intelligence Service in 2014. Mary has deployed to the Democratic Republic of Congo multiple times in response to this outbreak. And we have Ms. Fatima Khan, who is representing the WHO. She is here in New York and a very active member in the international community and in the diplomatic community in New York. Thank you. And with that, well, we do have a couple of other experts that I would like to introduce. One is Bibi Ndala. Stand again, Bibi. She's from the Friends of the Congo and the Ebola Coalition. She is a Master of Public Health degree from NYU. She's a monitoring and evaluation assistant with International Rescue Committee. Another person I'd like to introduce is Dr. Tamar Chaletse, medical doctor with expertise in infectious diseases with master's degree in public health, formerly of the Permanent Mission of Georgia to the United Nations. She also has quite a lot to offer. We will begin. I will be asking questions of each of the panelists, and I would like to caution everyone that there's a time limit on how long we can be here. So there will be a point in the program, if we are lagging, that I will be asking all the panelists to shorten their responses. I may also need to drop one or two questions to make sure that we get you in good time. I will ask a question, and that's directed to a particular individual. And if someone of the panel who wants to make an additional comment, they can make a comment, just one comment. Don't want three persons to comment. One person can make a comment on something that another panelist has said, perhaps show a different perspective, and to keep it very short, 1 minute. So we will begin. Are we all ready to go?
Yes.
Ready?
Great group, I must say.
So
I can't wait to hear what everybody has to say.
Yes, it is a great group. Immense qualifications, and even those who are in the audience are also great qualifications. The first question I have is to WHO. Why we will focus on, this panel will focus on the current outbreak of EBD in Eastern Congo. I would like to go back to early 2018 to the outbreak in the Equator province. In that case, the outbreak appeared to end very quickly, lasting only a short 2 months, from 18 May to 24 July. Over that time, 13 persons were reported to have died. The last situation report from the WHO about Equator in July 2018 declared that the outbreak was at an end. Then the first situation report about the outbreak occurring in another part of the country in North Kivu was issued a month later in August 2018. I would like to ask, how did the outbreak in Equator province end in such a relatively short time? What were the practices that were adopted at that time to combat it? And did those practices differ from what is being done in the current Ebola outbreak in Eastern DRC? Finally, why has the outbreak in Eastern DRC lasted so much longer than the outbreak in Equator, over a year?
Thank you, Gordon, and thank you everyone for coming here on such a beautiful Saturday. I know it's a gorgeous day outside, so I appreciate you're all here to listen to this interesting topic. I'm glad you asked that question because I think it's very important to understand the context of the current outbreak and also the previous one in Equator province. So before I answer, I wanted to flag that this is the 10th Ebola outbreak that the DRC has responded to since the disease was first reported in 1976. And just to give you some numbers for this current outbreak, and as of Friday, we had 3,228 confirmed cases. We've seen 2,157 deaths and more than 1,000 survivors, which is really important to note because in the past, the survival rate was much less. And this is because we have come so far regarding therapeutics, the experimental vaccines, and our response has gotten so much better. So I think it's important to share that. You rightly noted that the previous outbreak in in Equator Province had ended fairly quickly as compared to this one. And to give a little bit of background, that the Ministry of Health of the DRC reported to us on August 1st, 2018, of suspected Ebola cases in North Kivu Province. Following lab testing, we were able to confirm that it wasn't in fact Ebola, but it was a different strain of Ebola than in Equator Province. So the two outbreaks are not related, they're different outbreaks. And this is something that I'm sure that our colleague from CDC and others will speak about more about the origins of Ebola, which is still something we're still trying to understand. The reason why we are still facing an outbreak now in Kivu is because of security. The security situation is something that we have not seen before. This is very particular to this, and just to give you an idea, from the beginning of this year to 10 October, and we've been, knock on wood, we're lucky that we haven't seen more security incidents yet, and we hope that we won't see any more, but until that time, we had documented 307 attacks on healthcare workers. We have also reported 5 deaths, including a colleague of ours, Dr. Richard Mizuko, 70 injuries as well. And there's a constant state of insecurity in that region, and this is why the response is very particular. And another thing that I think it's important to flag is that the DRC is facing a major humanitarian crisis for over 20 years, and so they're dealing with not just Ebola. There's other issues that the country is facing. For instance, cholera, measles, malaria. Up to now, malaria is the lead cause of death in the DRC. We have, malaria has killed more than 48,000 people every year so far. It's much more than this particular Ebola case. The DRC is also the second largest food crisis after Yemen in the world. So there's really a lot more going on than just Ebola right now. So it's a very complicated crisis on top of the security situation in the Kivu area where we're seeing the crisis. So just, I think that's important for us to keep in mind as we talk about this crisis.
Okay. Thank you very much, Fatima. I note that the very first Ebola outbreak, I think in 1970, something by the Ebola River, that's where it got its name. That also simultaneously with that outbreak, there was an outbreak, I think, in Sudan.
That's true.
And it was a completely different strain of the virus.
Exactly.
So are these two viruses going back and forth, or what is the situation? Perhaps you wish to.
Sure. So, we don't know exactly. It's not been 100% confirmed, but we suspect that the natural reservoir host for the Ebola viruses the family of Ebola viruses is in bats. So there are 6 different, let's say, strains of Ebola virus. So Zaire Ebola virus is a strain that's affecting the DRC right now. What you mentioned in 1976, there were concurrent outbreaks of Zaire Ebola virus as well as Sudan Ebola virus. But we feel that all of these 6 different types of Ebola viruses are naturally found in bats, and we believe that to be true because of similar studies we've done in other families that are very similar to Ebola virus. For example, there's a virus called Marburg virus. And we found that in Marburg, the natural reservoir host is bats. And so these viruses infect bats, and not all bats, just a small percentage of bats. And the virus, when it infects the bat, does not cause any disease in the bat. And the virus can be shed in the bat's saliva and the urine and the feces. And so then the bats within themselves, because of biting and fighting and whatever, will then spread the virus amongst each other. And then then somehow people then get exposed to these same contaminated fluids. So some of the theories are, it's usually fruit bats, so it could be that, people in some parts of the country, they eat bats. It's an important protein source. And so in the process of butchering and hunting infected bats, people can get exposed to the virus directly. The other possibility is through intermediary animals like like monkeys. Again, monkeys, antelope, things like that are also a source of protein in many countries. And so what happens is that the bats, whether it's through their feces or excrement, which is on the ground, or maybe they eat some fruit, falls on the ground, is not contaminated with the saliva, the animals will then eat these or become contaminated with these other things. And then when these animals get infected with Ebola, it actually does make them sick. And so it makes them easier to catch. And so then people will catch these sick animals and then, sell it or eat it, butcher it, kill it, that sort of thing. And then people then become infected. But the general feeling is that for each of these outbreaks, that there's one transmission from the animal population to humans, and then subsequent human cases are all due to human transmission. So it's not that bats are continually infecting the human population. We feel that likely happens once, and then subsequent transmission is person to person.
Great. Thank you very much, Dr.
Mm-hmm.
Dr. Choi.
Yeah.
I know Dr. Stevens will want to have something to add to that, but we'll get to that later, not right now. I will follow up with another questions to you. What is the CDC's role in DRC at the moment? And also with regard to vaccines, you are a medical epidemiologist with the CDC, and as someone who has provided expert support for the DRC response and is knowledgeable about the investigational vaccines and treatments, will you give us an update on the status of the vaccines that have been used to date during the outbreaks, both in Equator and in Eastern DRC? How effective have they been? What have been the problems involved in their distribution? Can you also tell us what is currently in development and their effectiveness? I don't end there. And a related question, is there currently a pre-exposure prophylaxis for individuals at potential risk for exposure? That is for health workers or family members. And can you tell us also the trials, treatments that are being used in the current Ebola response? Have these treatments been effective in helping people survive? What are the resistances and risks?
Okay. So in terms of CDC's role, we do have deployers in DRC. We also have deployers in surrounding countries, South Sudan, Rwanda, and Uganda, as well as we provide some support to WHO in Geneva. And so in DRC, our role is primarily to support the Ministry of Health. So the Ministry of Health, in their response to this outbreak, has divided their response into various pillars. So one of them is surveillance, so the epi pillar. So we will have people from CDC sitting with the Ministry of Health surveillance pillar and helping them, in terms of developing their reports, analyzing data. There's also a pillar that works on vaccination. So we have, again, people sitting with these different pillars. Because of the security constraints, U.S. government personnel are not allowed in many of the hotspot areas. So right now, our staff are either in Kinshasa or in Goma. And Goma is kind of where it's kind of like the epicenter of the response. So a lot of the response is being led ideally like from Kinshasa, but really from Goma, because Goma is a little bit closer to the field. And so most of our CDC deployers are in Goma. On a case-by-case basis, depending on what our security and embassy allows us to do, we can then make other trips into other areas like Bunia and places like that, but that's really on a case-by-case basis. So that's kind of what we do. In terms of the vaccine, yes, you are correct. There is a vaccine that's being used in this outbreak, and it was used in the Equator outbreak. It is the recombinant VSV vaccine, and is currently it's the Merck product. So the vaccine was used in Equator. About 2 weeks after that outbreak was declared, they started using the vaccine. At that time, the people who were being vaccinated were basically contacts of a confirmed case, someone who had exposure to the confirmed case while they were sick, as well as contacts of contacts. So a little bit removed from the confirmed case. So maybe people that live in the same area and that sort of thing. In the current outbreak, initially when it was rolled out, it was actually rolled out much faster. So they started vaccinating about a week after the outbreak was declared. And initially, again, the vaccine was limited to contacts and contacts of contacts. Also, as it was in Equateur, it was limited to adults, and it was not eligible. If you were pregnant or lactating, if we knew you were pregnant, lactating, then you were not eligible for the vaccine. Currently, when the vaccine first got used in the current outbreak, they again kept these same parameters. So adults, you can't be pregnant, you can't be lactating, you can't be a kid, and you had to be a contact or a contact with contact. They've expanded that, so they're vaccinating frontline healthcare workers, so response workers, healthcare providers who are in the area. They've also changed the eligibility criteria so that now women who are pregnant after their first trimester and lactating women, as well as children, are now able to be vaccinated, which is different than what it was in Equateur. If you look at a curve, the outbreak curve of this DRC outbreak, and you compare it to prior outbreaks, including West Africa, for West Africa, we had this very exponential rise in cases, and so we got into a high number of cases very, very quickly. And we're not really seeing that in this current outbreak. The slope of this is a little bit more gentle. And certainly we don't know all the factors that are influencing that, but certainly the vaccine probably is playing a very large role. In terms of efficacy, when they first used this vaccine in Guinea, they found efficacy about 100%, Right now, they've done some studies and they found it to be about 97.5%, so pretty efficacious, as long as you get the vaccine before you're exposed, and that's the way it's most effective. In terms of therapeutics, this outbreak was the first time that there was a randomized clinical control trial. So they actually studied 4 different therapeutics on people coming into the Ebola treatment centers. And that study ended up finding that 2 of the therapeutics, a product called Regeneron and MAB-114, both of which are something called monoclonal antibodies, both of those have been actually found to be very efficacious in treatment. And so normally we quote mortality rates. If you're infected with Zaire Ebola virus, the mortality could be 70 to 90%. In the current outbreak, it's about 70%. But in all comers, if you give them either Regeneron or MAB-114, the mortality rate drops to about 20, 29, 30%. And if you are infected but come early in the course of your of the disease, the mortality is even lower. It's like 6 and 11%. So, because of the study, we're now able to identify 2 new products that can markedly improve mortality rates in people who are infected with the virus. With regards to pre-exposure vaccination, so right now the Merck product is seeking FDA licensure for use in the United States. That process is ongoing. Merck has publicly announced that they expect a decision to be made by March of 2020. Right now, in terms of availability of getting this vaccine for people in the US who are responding, it's limited to clinical trials. So there is a clinical trial called the PREPARE trial. It's an NIH trial, and they have sites at NIH as well as Emory University in Atlanta, where people who are at occupational risk for exposure to the virus can be vaccinated. And so several people from CDC and other individuals have been vaccinated. People from Europe have also been vaccinated. They're vaccinating at the University of, I think, Geneva. So that is currently available. Right now, we are working with the organization that makes recommendations for vaccines in the United States to make recommendations for this vaccine in the event that it is licensed.
I see. Okay. Thank you very much. But I want to ask you something, if you can give a quick answer.
Yeah.
In West Africa in 2014, the efficacy rate in Liberia, Guinea, and Sierra Leone was different. And the survival rate was also different. It was different. What accounted for that? I mean, it was the same virus and the same medication, the same vaccine that were used.
Right. So so the vaccine was used in a trial in Liberia, and also it bring vaccinations there, and it was also used in Guinea. When the vaccine was used at the time, it was used at a time where the outbreak was actually kind of waning, okay? With the current outbreak, it started getting used right up from the beginning. Also, in West Africa, we had, again, everything got started late. The remdesivir was available, as was ZMapp, and so those were the therapeutics that are being used. But because, again, at the time that they were being used, it was so late in the outbreak, it was really hard to show that they actually, whether they worked that well or not.
Okay.
But when this outbreak, it was started
Right from the start.
From the beginning.
Oh, thank you very much.
Mm-hmm.
Thank you. I have a question for you now, Dr. Akana. You spent 7 years in the DRC, and you conducted research in both the Equateur outbreak and an early outbreak in Shuapa in 2014. You were a consultant anthropologist for UNICEF in 2018 on the social, economic, and cultural impacts of the epidemic and the response. What were your findings in this area? You also conducted social science research in the region, looking at the repercussions of the experimental vaccine. How did you conduct your research, and what were your findings?
Okay, thank you for the question. So maybe I'll talk a bit about the UNICEF, the research that I did for UNICEF, which was in August and September of last year, and it was in Equateur. And what I did was, with a small team from UNICEF, conducted nearly 100 interviews in the Bandaka area, which was the city, the capital city of Equateur province, and then also in the health zones where there were the most cases of Ebola and where the cases had started, so Iboko and Bikoro. And I attempted to speak to as wide a cross-section of the population as possible. So I interviewed local administration, also health workers, local health workers, and local leaders, including religious leaders, leaders of women's groups, of agricultural groups, of youth groups, community health workers, and I also spent time with families of Ebola victims and Ebola survivors. And so the questions that kind of framed that research were, firstly, what were the enduring social, economic and health consequences of the outbreak? Because very often a lot of resources are deployed to end an outbreak, but there isn't always such a consideration of what actually happens after the outbreak. The second question was how local health actors and community members themselves perceived kind of both the successes and the challenges of the response itself, and then what kind of insights they might offer as to how we could improve responses in the future, and especially with a view to, so the whole project in a way was looking at life post-Ebola, so that we could think about, have a view to outcomes post-Ebola right from the beginning of the response. And so maybe I can summarize some of the economic, social, and health impacts. So, I mean, the health impacts are pretty clear that not only are there enduring health issues known as post-Ebola syndrome for survivors of Ebola, which include eye problems, enduring weakness and muscle pain, but there are also, for them, mental health issues that are very important. And there's a kind of broader, in the society as a whole, there's also many psychosocial issues for families of Ebola victims and for people more broadly. And so that also kind of points to these social repercussions, that there's a torn social fabric in these communities, which is based on the fear that they experienced, also on the fact that you wouldn't do these normal acts of care of going to funerals. Like, people were afraid to go to funerals, they were afraid to care for sick relatives in some cases, or at least to visit, as you often would do, sick neighbours. And so this kind of really eroded, even though it was for quite a comparatively short period of time, of several months, it eroded the social fabric. And then there are economic consequences, including, and these are sometimes exacerbated actually by the response. So one that people talked about was a food crisis. And this was based on the fact that people were kind of isolated or in quarantine and not able to work on their fields during the Ebola outbreak. Then there are impacts on labour also, that people now with less family members or people who are recovering from Ebola can't work in their fields. There was also stigma, which led, there's Itipo was the village that was kind of the most hit by the outbreak, and it normally has a market, but that market kind of closed down because neighbouring communities were afraid of catching Ebola, and they still didn't come back after the end of the outbreak. And then another part of the food crisis, and people talked about just the cost of living having increased, because the responders who came in, and at one point there were over 200 of them in Itipo, which is a tiny village that has no running water, no electricity, that they were buying, they brought in a lot of their own food and water, but they were also buying local goats or chickens or things to eat. And this made the cost of these domestic livestock go up really significantly, meaning that even after the outbreak, people couldn't really afford to buy them. It also put pressure on the local ecology in terms of water that was used not for drinking but for washing and things like that. So yeah, some very significant kind of impacts that should be considered, and that right from the beginning, response teams should be thinking about how to think about potential impacts with local communities, that they really would, this is, I mean, we're going to talk about community engagement later, but that really there needs to be discussion with local communities right from the beginning of the kinds of impacts that these responses can have.
Excellent, very good. Did you develop your questionnaire? How did
Yes.
you develop it?
I
Personally?
did. I personally developed it based on, in fact, so I developed it personally, but obviously in discussion with UNICEF,
Right.
but I kind of pitched it to them as based on the research that I had done in the Bwinde outbreak, which was the 2014 outbreak, and where I had seen significant challenges post-Ebola. And so given that UNICEF has maintained its presence in Equateur, they were interested in what they could do post-Ebola, as well as just during the response.
Right. I assume you submitted your report.
Yes.
And hopefully some action has been taken. Are you aware of any outreach or psychosocial support, anything like that?
Yeah, so, well, there was actually already psychosocial support happening, both with, you might know about Alima, which is, has been providing some of the Ebola treatment centers along with MSF. They have a psychologist who works specifically with Ebola survivors. And there were otherwise psychosocial teams that were supported by psychologists from the University of Kinshasa. But as to recommendations that have been taken up, these things are circulating within the social science and the broader communities, and I think I've also contributed to the social science and humanitarian action platform briefs, and these are all kind of things that are debated and that people try to implement and are trying to implement in the Kivos as well.
When are you going back to DRC?
I just came back in August.
We need you
I
there.
should hopefully be back there in January.
Okay, very good. Thank you very much.
Thank you.
We've really heard some very interesting statements and reports from WHO, CDC, and of course Dr. Kernan. I haven't gotten to Dr. Judy as yet. I'm going back to WHO now, Fatima, and I'm going to only give you 2 minutes for this, or less. About stopping the spread of the disease across borders, what type of illness surveillance is conducted at the borders between DRC and adjoining countries? How do you identify if someone is carrying the virus, And then what is done if you identify individuals who appear to be ill?
Thanks for the question. I will be very, very brief with this. It's quite a simple answer because really, first, the only way to know if somebody has Ebola is to get a blood test.
Right.
The symptoms of Ebola can look like many things on the onset, but the best way to trigger an alarm is through taking temperatures. And so for crossing borders, the best way to start the process to see if somebody is sick is to take temperatures. And that's when we have screenings and, led by the DRC government around all of the border areas to screen people for temperature. And then in case somebody shows that they have a higher temperature, then they're isolated and then taken to appropriate medical facilities for further testing. And this is, so far, that's been the best way to screen for possible Ebola cases thus far.
Right. What's the current, what should I say, status of cross-border infection?
Well, what I can say is up till now, through this kind of screening, we have identified 28 cases that have been, that could have potentially crossed borders or have been. So I think it's a good method. Having said that, you've all probably heard that there have been cases in Uganda as well, and it's not, I mean, you all know very well what DRC looks like, and the borders are very porous, and as much as you try to have screenings across the borders, I think it's safe to say it's just impossible to document every single person moving back and forth. And then there's also some cases where farmers have land that are, partly in DRC, partly in neighboring countries, and so their daily life is, moving around, between the borders. So it's as much as we can, we try to,
Right.
to screen, but, it's
Right,
it's
it
not
seems like
perfect.
it's been quite
Yeah.
successful so far, for the cross-border transmission has been kept to a minimum.
I think so, and that's really a testament to the preparedness efforts, which I wanted to really raise that, I'll come to that a little later too, but the preparedness efforts being done with neighboring countries is really the reason why, we prevented the spread from going broader, and that's something that is so important, just to continue to invest in preparedness. It's not a sexy kind of issue to invest in preparedness because you're preparing for something that didn't happen yet.
Right.
And so you can't really measure. But the success rate is exactly that. If you have, for instance, Uganda has such a great preparedness system in place that they've had Ebola cross into Uganda over the summer in June, July,
Right,
and
1
August.
or 2%.
And yeah, it was very small, and they were able to contain it and prevent the spread. So, it shows that it really works. So that's something, we don't have member states in the room, but it's something that we really try to push with our donors, to
And
invest in preparedness.
Preparedness is coordinated by WHO, UNICEF,
And others work,
CDC.
CDC,
A
World
whole range
Bank,
of
yeah, a whole range
partners.
of partners. I
I
mean,
see.
this is really something that just one entity can't do it alone. It's really a multi-partner approach, and we work as one team.
And of course, you have to give credit to the governments who
Oh,
are on it.
absolutely. I mean, the DRC government has been fantastic
It
as far
appears
as
so.
leading, yeah.
The next question is for you too. And I'm sure that other panelists will want to jump in and say something. And I'm going to allow it, but I'll allow other panelists to have no more than a minute to comment.
Very strict, Gordon.
WHO mentioned that community engagement is the key to successfully controlling outbreaks. We understand that UNICEF is primarily responsible for this aspect. Is WHO working closely with UNICEF on this? However, given that many different partners are involved in fighting EBD and must have their own methods of community engagement, are those in the field given some uniform or basic training? What is the training and specific techniques for engaging the community? If more than one organization is involved in community engagement, how is it coordinated? Are methods and practices coming from the same playbook? Can you describe what this looks like?
So start briefly, but then I will turn to our former UNICEF colleague who probably has a lot of on-the-ground experience. You're absolutely right. It's one of the most important aspects of ending the outbreak, and really one of the hardest things to do in this current outbreak, especially going back to this issue of insecurity. And it's not just for DRC and Ebola, but it's across the board. I mean, when we work, for instance, in Pakistan with polio eradication, community engagement is important. Each context is different. Each community, each country has, there are different issues at play, and we need to really make the effort to understand what's happening. And it really entails understanding, respecting the local context, making sure that we're entering into dialogue with communities to really hear what they need, what their concerns are, what their fears are, consulting with them, and then looking at and empowering them, because it's really, you know, it's their communities, their country. They really need to be in the lead. We're just there to support and give the tools when necessary. One thing that we have done to support community engagement is, rightly as you say, it's good to, WHO is, you know, we're really good at producing guidelines. So that's one thing that I can say we're great at. And so we have some guidelines that are publicly available, and you can all access them on our website. But we have some good guidelines, especially specific to this Ebola outbreak, on how to, guidance for risk communication and community engagement. So there's a list of, you know, and this is also, just to say, it's currently being revised, because we're learning as we're doing as well. You know, we can't say that we just put out one guideline and it'll never change. So we keep on revising it. So, and this guideline really is meant to support health workers, communities, NGOs, ourselves, UNICEF, other colleagues on the ground to come up with, you know, a set of tools to how to engage with communities. And but this is just one of many. There's many other ways to do that.
Okay. Thank you very much. It's obviously not a very simple process, but an absolutely necessary one. Dr. Tyler,
Yeah, so,
would you like to comment?
yes, I'll try and keep it to 1 minute, but you might have to cut me off.
I did it in before.
So in a way, it's sort of problematic that community engagement is also lumped with risk communication, because I think sometimes it can be then overlooked in favor of risk communication. And it's just like Fatima was saying, that is one way that you're sort of educating people, and that the whole point of community engagement is that it needs to be two-way. And it also needs to be at various levels. And so it's not enough to have engaged with local leaders. They also, and who are those local leaders is another question. Very often, because this is such complex work, local leaders will be identified as the sort of most prominent and those who self-identify, but you might at that time overlook marginalized communities, you might overlook women, you might overlook the elderly or youth groups, you might overlook all kinds of people, and so really work needs to be done to be engaging with communities at many levels and getting really responses from them on how to proceed at the village level also. And the other thing, I mean, the thing to emphasize is really that communities are not being engaged enough, and even resources are kind of being drained where they should be being reinforced. And so you have health workers being taken away from ordinary small clinics to Ebola treatment centres, which then leaves the populations living near those small clinics open to all kinds of diseases, which, as you've already said, are probably more likely to lead to morbidity and mortality, like malaria or measles.
Absolutely. It's one of the most complex issues, community engagement, but the most important. And I mean, I think all of us who work in the UN system and others are the first to say that, yeah, this is one that sometimes gets lost when we look at a response, because we jump into the epidemiology, we jump into the contact tracing, and then we just miss this part, you know, just because it needs to come naturally in the future, and we hope we're getting there.
Okay. Thank you very much, Fatima. Thank you very much, Dr. Akana. The next question is for Dr. Judy, but I'm going to warm her up with her take on this community engagement question that I just posed.
Well, I think I've been very enthused about what I've been hearing from my colleagues here that really cover how complex this particular outbreak is in the DRC, and how similar in certain ways and yet how different it is from what happened in West Africa, where I actually was during the height of the Ebola outbreak in Sierra Leone in 2014. And now we are planning actually an intervention called by the Ebola Coalition, made up of a group of stakeholders here in America and many stakeholders who are actually on the ground. So this is a partnership of people who are here and experts and who have lots of experience, including myself, in lots of disasters, as Gordon said, and also in outbreaks like Ebola and also SARS, I might mention. So what we are interested in is taking a holistic report and a holistic approach, which does include 3 pillars, one of which is community engagement. That means involving the community and really having the interventions come from the people. The second is risk communication, which has to do with people understanding what Ebola is, that it's real, because there are so many myths. And the third is psychosocial support, which is my particular expertise and which has been mentioned here and overlooked, and which is extremely important now. So now that we have some sense of control over the medical aspects of this, we need to look at what is the psychosocial needs of the people. And all the people we work with on the ground say, this is what is really important and fundamental now. So as the outbreak becomes controlled and there are few medical cases, people are in trauma. The fear, the anxiety, the panic, the loss of loved ones, of work that we have heard about, what's called the Ebola economics, is just very widespread. And from my work for many, many years in many disasters, we know that these psychological upsets last for a very long time. It's not that just the cases have gone down, we're so happy about that, but people are still disparate, which has to do with community disengagement, and they're in tremendous triple trauma. Trauma from what we've heard of, the fact that this outbreak is a complex outbreak. Why? Because it is not just the medical problem of Ebola and the psychology of it, but it is the violence in the region. People are being murdered. Even the people that we are working with in the Ebola Coalition that we have formed, one of them has been murdered. The person who took over from that person was airlifted out of the country because of the difficulties and all the violence that's coming from all different places. So that has contributed psychologically to the mistrust of the entire population. So there are psychological dimensions here that are so complex and layered upon layered upon layer that we are going to be approaching here. A lot of them has to do with the mistrust of the government, the mistrust of emergency people, the mistrust of doctors. I mean, the MSF, the Médecins Sans Frontières, the Doctors Without Borders, ETU medical center was bombed, and they had to send people home. Why? This is because of the confusion that people have, and that you don't know where people are that you can trust or mistrust. So trust is an issue. Also the myths that are going on. There is tremendous myths that existed in West Africa and that exist now in the DRC, with people not understanding, is Ebola real? They think that many things, that the white people have brought Ebola to wipe out the black people, that the international organizations have come to make money because they need to build their coffers. They think the government has brought Ebola to wipe the people out. That's another myth. They think the witches, have caused Ebola. There are so many myths that prevail that need to be dispelled through community leaders, and community engagement is one of them. So these are the psychological issues that we're facing. I call it the holistic psychosocial aspects of a deadly epidemic. I wrote this book after being in Sierra Leone during Ebola. What Ebola has taught us about holistic healing. Fortunately now, as I've heard from my colleagues here, that we're not just looking at an outbreak as a medical issue, but psychological. And there is a foundation in international instruments about this. Fortunately, we have the foundation of what Gordon mentioned before, the Sustainable Development Goals, the UN Agenda 2030 for Sustainable Development, which has 5 words in it that I'm honored to say that I helped get in there with Ambassador Otto of Palau by helping make on the international level at the UN. 193 governments recognize that, wait a second, we have to have psychological and psychosocial and mental health and well-being in this agenda, along with eradicating poverty and creating peace in the world. So those 5 words are part of the foundation. Also, Dr. Tamar Taliti is here, and she was one of the co-drafters of the new Universal Health Coverage Political Declaration. Paragraph 1 says, medical and mental health, physical and mental health, foundation for all care for all people. So paying attention to people's feelings and their emotional needs and their trauma is critical in this. This is so thank you, Tamar, for all that work. Georgia and Thailand were the leaders in this effort that you will tell us more about. So in summary, first in 2014, the United African Congress, which Gordon is the president of, and now the ambassador of Sierra Leone to the United States, who was then the president, and we have a chairman, Dr. Mohamed Nouri saying. So as a group, there was the first people to highlight that Ebola was a problem, even before WHO had declared it an emergency. And there were events at the United Nations, a huge concert in the General Assembly Hall, and events at the UN to say, this is a serious issue that we have to pay attention to. My own psychology coalition at the UN, which is made up of psychologists like myself who are accredited at the UN, we held many side events along with Voices of African Mothers and many NGOs, my own and others, with governments who came, the governments of Guinea and Liberia and even the Netherlands, donor governments, and Uganda, who came together and said, this is a problem. Then later, I created with Gordon another side event that Sierra Leone was the sponsor of, to say we have to continue to pay attention to this. When the cases go down, we still have to continue with the prevention, as Fatimi was saying, and also with the psychosocial help. So right now, with regard to this particular outbreak, we have a coalition that we've developed, and that coalition consists of the United African Congress, the International Association of Applied Psychology, a group called Halt Ebola, Hope and Health Vision, which is on the border of the DRC and Burundi, that's been working there for many years. Some people actually who are also involved with WHO, and Friends of Congo, which is really what we're here for and who have supported us. So all these groups are coming together to create an academic training program. This is like totally major, that we have a formal invitation by the university in Beni and Butembo to come and do a teaching program for the pastoral students who want to learn about psychological counseling so that they can work with the community, which goes back to community engagement, and also specific workshops and trainings that are going to be based on things that we know other people have using, pieces from the WHO guidelines that we know of, and all the MHGAP things, and the ones that this is my student, we were just in Geneva, WHO, at the Mental Health Forum. So actually I have 2 students here from Colombia, if you could just wave your hands, who are working on this project, who came with me to Geneva. And so the idea is that we're going to create a sustainable training program for pastoral students who will then not only learn didactics, but experiential workshops that are very useful with different activities that I do, with throwing the ball to kids, and very simple, not with exercises that don't require a lot of language, because the language is an issue there. It's not just French, but it's also Swahili. So this is our plan to train the trainers, as it's called, and to create a sustainable teaching relationship, and to address the long-term psychological and community issues that are in the region. So just for this particular time, I'll stop with saying one of the techniques are meant to encourage empowerment, resilience, and community cohesion, which relates to the community engagement here. So one of the techniques is to create hope. And so we take a ball that has written on it what my hope is. It's been written in Swahili. And we have the kids come into a circle. And one of them steps in the middle and says what their hope is for the future, because many people don't feel there is a future. And then they say what they want to be. I want to be a teacher. And so they throw the ball to the next person. Oops, and you catch it. Can you grab the ball? Okay.
You want it back?
Well, I wanted to throw it to you.
Oh, good catch,
And
good
then
catch.
you need to stand up and say my name is, and I want to be, stand up.
Fireman.
My name is Jim Gokwe, and I want to invest in Congolese entrepreneurs.
Oh, wonderful. So then the rest of the kids in the group say, hello, Jimagukwe,
Gokwe.
Jimagukwe. You are investing right now in African entrepreneurs and in DRC. How do you feel about that?
I feel great.
Wonderful. Thank you. So that's just a simple exercise to show what we intend to do. And working with children is very important, because they really not only are the future, but adults can learn through teaching for the kids when they're really also learning for themselves.
Thank you, Julie. You've actually answered the two questions that I had posed for you.
Well, they seem to flow.
But I can see you're overtaken by your passion for what you love. That is fine. I will still get back to you. We should point out that the partnership with the University of Beni and with the Catholic churches in Beni, bishops in Beni, what the discussion with them, what we have at this moment, it will be a certificate course that will be taught. Or credits, we have not yet exactly determined what it will be, but it will be a very intensive course. And Julie will describe it more, because it's not just training and walk away. There are a lot of other things involved. A lot of monitoring, a lot of testing it to see how it works, and before they go out on their own, and then it will be monitored. It will be a very important exercise that I believe when we have the results, we will scale it up, and we think it will be something that will be adopted by other organizations. These are universities who have students who want to help their communities, but they do not have the medium to help their communities. They don't have a platform, and they're not organized to do it. We will do it as a model. Right, Julie?
Wow.
Yeah.
Well said.
Okay. Now I'm back to Dr. Stevens. One of your qualifications that I find very interesting is that you are an expert at animal-human relations, even though you told me that you're not an expert, but you're trained in that. As you're aware, WHO and other organizations have pointed to animals as a possible origin of the Ebola disease, which we also heard reinforced by Dr. Choi. There is no dispute to this. However, as a socio-anthropologist, please comment on bushmeat and its possible role in transmission EBD, given that communities are impoverished and that selling bushmeat supplements their income, and it means the difference for them putting something on the table or not? And how do you balance that against the fact that wildlife is being depleted in the country?
Thank you. Yeah, so I'm not a biologist or an ecologist. That's why I sort of, and the sort of, I guess the qualification of being someone who has studied human-animal relations in the past comes from the research that I did for my PhD, but also the postdoc that I did at the Institut Pasteur, which was part of a project looking at human and great ape interactions in Central Africa and connections with zoonotic disease transmission. And so, and zoonotic diseases, so diseases that humans catch from animals, actually account for 2/3 of all diseases that we have from those that have sort of crossed into humans and then become kind of passed from humans to humans, like HIV, to those which are kind of crossing continually back and forth, like yellow fever or malaria. And I don't have too much to add to what Dr. Choi said about the route of transmission of Ebola to humans, except that to maybe again emphasize that I think it's only in a few outbreaks in the Republic of Congo around 2001 that there were multiple spillover cases, but that in most outbreaks, like she said, that there's perhaps one event and then it's really being passed from person to person, and that this is really a disease that thrives on acts of care. So that the important thing to really underline is that it is being transmitted from person to person through caring for the sick, through funerary practices, and that kind of thing. So coming to the question of bushmeat, I kind of want to talk about why it can be risky to, or messaging around bushmeat can be quite risky. Well, firstly, because it isn't the biggest risk probably that people are facing when we're talking about Ebola transmission. And then secondly, anthropologists from some of the earliest Ebola outbreaks in the Democratic Republic of Congo and the Republic of Congo have talked about the way that that kind of messaging can actually alienate communities who rely on bushmeat for food and as part of their local economy. And that can actually turn people away. They'll say, you know, we've eaten this food from the forest for generations and this hasn't happened before. So there's something else going on here. And I kind of wanted to talk briefly about myths. So we talk a lot about kind of myths and misinformation with Ebola, and a lot of myths about Ebola's origins, or what we might sort of talk about as a spillover event in biomedical terms, are often framed by people also, by local people, as coming from bushmeat. But the framing is very different, so that it will be that a hunter went out with a particular fetish or something and he didn't obey all the conditions, and so now he's being punished by the ancestors or by the féticheur. Or it will be that someone stole an animal from a trap. So there's a very different framing, and it's also, this framing is also the reason why these kind of myths cannot be easily dispelled. Because in Congo, as in much of sub-Saharan Africa, there's always a question which goes beyond biomedicine, and it's always, but why? So there's this famous example of an anthropologist, Evans Pritchard, who wrote about the Azandi, who live in South Sudan near Congo, and a barn collapses because of termites and kills a man. And people will say, yes, we understand that it was the termites that crumbled the barn, but why at that moment? Why never before? And so that's why these are, you know, yes, there maybe is Ebola, but why? And so people are looking for also these other forms of explanation. And
1 second.
yes.
You know, the next question I was going to ask you, what are the cultural and societal customs that hamper the fight against ED?
Right, yeah.
So which is,
So shall I
just
finish and then just
continue
keep
with
going
that.
on with that
Yeah.
one? Yeah, so maybe I can just go straight to that one. So with that, typically what we say are that it could be, for example, all these acts of care, of burial, of caring for the sick, that might contribute to the spread. But what I would really like to emphasize is that it is it's a lack of community engagement that actually contributes to the spread, and it's also these other kinds of sources of explanation and lack of trust that are circulating that really are around this huge sort of can of worms that we probably don't have time to go into great detail about, but that is this Ebola business. That, and it's something that I noticed as one of the central things, even with the Bwinde outbreak that I worked on, and I'm sure in many of the outbreaks before, the people in Bwinde would say, they would refer to themselves as Bakolo Ebola, that we're the originators of Ebola, and yet we didn't profit at all. It was all of these people who came in who have profited from this disease, right? So there's a psychological. This is a disease with great psychological impacts, and viewing it through a psychological lens is very important. But it's also very important to view it through an economic lens, which is the way that many local people view it. And so you even have reports of in Goma, people saying we want Ebola to come here so we can get a cut of the Ebola money. And you also have a lot of the rumors that are circulating are about people saying that there is an economic interest in this Ebola outbreak, and there's then suspicion that it is local elites who are trying to actually perpetuate the outbreak because they can make money renting their jeeps out to WHO and other responders, or renting out hotel rooms, all of this kind of thing. So this is a huge issue that is actually, I think, more important to consider than issues around burial or other customs that can, because this is the big question of trust and about the way that people are viewing this
Right.
epidemic.
Okay, thank you very much. Very interesting. Fatima, would you like to add something to that?
No, I think you raised a very good point. I don't think I have anything to add.
Dr. George?
No, I mean, I completely agree. When you go back to West Africa and Liberia and places where the outbreak were, where there were a lot of international deployers, you'll see that all the hotels that they stayed at, they've all built additions. They're much nicer. They now have a coffee bar. They have a new pool, and it has to be because of the amount of money they honestly generated during the outbreak and supporting people.
Wow.
So, yeah.
So it does have both a positive effect and a negative effect.
Yeah.
Right. That surely
I think
elucidates.
that what you're saying just emphasizes the holistic view of this issue, that underlying the difficulty in the health infrastructure really being decimated and not really being supportive of this. We have extreme poverty that leads to all these myths and all the some people taking advantage of the situation in reality that perpetuates the mythology. So it's a social, economic, psychological, medical problem on all levels.
Okay. Thank you, Judy, for your addition to that. I had planned on 45 minutes for Q&A. But due to the fact that we don't have a full house, I'm going to reduce that time to half an hour and continue with our discussion.
And we show the video too.
Yeah, that's going to take place. We'll get to that. And this is for WHO. With regard to whether survivors are in fact totally cured, it has been shown that survivors may retain the virus in different parts of their bodies for up to 3 months after recovering from the disease, and they can still pass it on during sexual intercourse. Are survivors fully briefed on how they may interact with family members after leaving the hospital or treatment center? Are they given a brochure, for instance, about what to do or not to do?
So this issue of survivors is so important because it's not just about the physical aspect, but also the psychosocial aspect of what it means to be a survivor of this disease that comes with so much stigma, and then also reintegrating into the community, restarting your life again, your livelihood. I can talk about what WHO is doing in that regard, and we have follow-up programs for survivors for this outbreak that they're enrolled in, and that includes, and there's several clinics all over the country that are staffed by doctors, nurses, lab technicians, psychologists as well, and they go there regularly for checkups, for treatment, for eye care, because as one of the points you mentioned is that we found Ebola can continue on in the eyes as well, and so we monitor survivors, and up to date I think we've had over 250 survivors that have participated in these programs, at least for one program regarding looking at eye complications, and we also have programs set up specifically for survivors with particular needs, so pregnant women, infants, elderly, children who have recovered from Ebola. So there is a process. So it's more than just a brochure that we have to put out, because this is very complicated. And then the other aspect which our other partners look at is then reintegration to communities and looking at rebuilding livelihoods and other focuses that aren't directly public health related.
I see. Okay, thank you. Dr. Choi, you wish to add something there?
Yeah.
Is there a possibility that a vaccine can address that issue of the extra life of the virus?
Right. So, I mean, I think that's why we prefer a vaccine versus a treatment, because if you never get the virus, I mean, you don't have to worry about the virus persisting after you survive the infection. So, as to the question of whether these new therapeutics have any sort of effect on the persistence of these viruses and these bodily fluids after people survive, that's still being looked at the moment. So hopefully there'll be more data on that. The one thing I would clarify is that, in survivors, the virus can actually persist for longer than 3 months. So in semen, it can actually persist for years, and we have done studies to show that. And in Guinea, after the outbreak was, basically over, someone did transmit the virus sexually through unprotected sex 15 months after they had recovered from Ebola. So we do know that virus persistence in semen is something that happens, in terms of, transmissions due to sexual transmission from Ebola virus. The instances are rare, but it does happen. I was involved actually in a semen testing program in Liberia where we actually tested semen from Ebola survivors, and they actually have a lot of psychological issues because they were told that they were cured. And then we found out through the course of the West Africa outbreak that the virus can actually persist in semen for some period of time. And then and actually the first case where that was really kind of reported in Liberia, that person, they actually outed that person in the newspaper, the man. And he basically had to go into like some version of like a witness protection program, because everyone knew who he was.
Right.
And then now all these men who are then survivors were then looked upon very suspiciously by their communities. And so many of the people enrolled in our semen testing program, they actually moved, they had to move locations because of the stigma had come back. And so, I think that is something that is that is being addressed by the WHO survivor programs, but really needs extra attention because of this uncertainty that people have and the distrust that the community have. You were brought Ebola back to my country, is a lot of the things that are being said. Yeah.
Very serious.
I'm pretty sure that Dr. Julia and Dr. Lakaya have something to add to that, but I'm not going to take that. I'm going to go back to you, Fatima, and can you explain the strategic response number 4 plan that was announced by DRC last month? It calls for an additional 509 million in funding to bolster public health activities. Is there a detailed breakdown of how it is to be spent? For example, are any of these funds used for public communication, such as public service announcement? How are these funds used? How are they distributed? Are any grants given from this amount to NGO groups who are on the ground fighting the disease?
Okay, so this is, as you mentioned, the SRP is the Strategic Response Plan 4, so there are 3 three before this, and each time they've evolved to address the needs of the outbreak at the moment. So the current response plan is from July to December of this year. It looks at a few main areas, for instance, detection and response to cases, public health action around cases, strengthening community engagement, looking at health system strengthening, and coordination activities between local and international partners, and then looking at the linkages between public health activities, security activities, financial and operational sectors, so that's more the partnerships area. WHO is in charge of two parts of that response, and our focus is on the public health response and then the preparedness response. So for the public health response, we require 287 million, and for the preparedness, that's 66 million. Now, regarding what it's used for are different projects and programs related to these general activities. So in the public health response, we're looking at infection prevention control, contact tracing, lab diagnostics, and preparedness. It'll be strengthening health systems response, personal protection equipment, training health workers. Just to give you an idea, I'm not going to very technical details. And those recipients do include, of course, us, WHO, the UN partners, Ministry of Health, NGOs, just about everyone who's part of the response. And that goes back to this idea of working as one team to fight Ebola. It's not just WHO doing the public health response, and it's not just UNICEF doing community engagement, but it's all of the partners on the ground who are working together and who are going to access these funds.
I see. I'm sure Dr. Julie is very interested in hearing that there are funds for NGO from that.
Absolutely. I mean,
bundle.
we rely on the NGOs, really. They're the ones who do
Right.
the hard work on the ground, let's be honest. They're the ones who are front and center.
In fact, I should tell you that we've been doing an appeal for funding for our project when Dr. Julie rolls it out. But I want to ask you further. It appears that the World Bank has contributed over maybe 500 million or so from two different sources, and USAID over 200 million. Are the member states, contributing to this?
Yes. We need more, of course. I mean, this is a good plug for funding, but USAID, World Bank, and we have other donors as well who have provided assistance in different categories and degrees. And the EU, for instance, Italy, Germany, Japan. I mean, I don't have the numbers off the top of my head right now, but they certainly are, and we're continuing to advocate for this, because even though I think somebody mentioned earlier that we're looking at we're not looking at there's steady cases for the
Right.
moment, but at the same time, the cases are in very insecure, hard to reach areas, so we need to really push hard to get to zero. So it's far from over, and we are coming close to the end of the year, so we have to push hard to make sure that we get to zero fast.
Very good. Thank you very much. I wish we could keep this panel and travel around the country with it, informing people what's going on. It's been very informative. I must say I've learned a lot, and it deserves to be before an audience of 1,000 people over and over and over again. Anyway, let's continue. It's going to be time for that video.
Maybe we should ask Tamar before we show the video?
No,
Yes,
I
Tamar,
want
just-
to be prepared. It's going to be time for the video. Okay, wait for Dr. Julie will be speaking about her. Shall we
It's going to come behind
step
us.
down, I think?
Yeah.
We leave you alone here. So this question here, which will be to Dr. Judy. Dr. Judy is a central figure in our Ebola Coalition, a coalition of NGOs, major organizations and partners in the USA and in DRC, and we are planning a very exciting mission in Beni and Butembo early next year. Julia, will you please describe the project?
Right. So the key really is as to just summarize again what I had said earlier is
Not yet.
Can you wait a second?
Not yet. Pause. Pause.
Can you roll it back to the beginning? Yeah. Maybe they could start it up.
So roll it back.
Oh, sorry.
So we have been spending a great deal of time talking to various stakeholders on the ground about what is really needed for the people, because that's what's important. We could sit here and make up what we think happened, etc. But because we have partners on the ground and people who have friends there, who have family there, or who are working there to actually try to do this community engagement and create more resilience and empowerment in the people. The program that we're building up that I mentioned about the training project is really from the bottom up. So when we talk about grassroots, it's like coming from the people. And we're very grateful to the Friends of Congo who is offering us this entire week and this event here now, for really being one of the major connectors there to the diaspora here, and also the people on the ground who are going through this trauma. So all of the project that we are creating, the teaching materials that we are developing, all come from what the people are really saying that they need, that they want, and that they're suffering from. So we made a short video, which was very long, and then we compressed it to being something shorter about addressing the various issues that we've been talking about here. What do people think Ebola really is? Where does it come from? What are some of the myths? How do they feel about the vaccine? So you will see some of the answers that we put together from the people on the ground, acknowledging that they are answering in their local language, and so everything has been translated. And so we are very grateful to, again, our partners who are Congolese, who are through the network of Friends of Congo and Halt Ebola and the other groups that we work with, including the university now that we are partnering with. And so they have Dr. Kasarika, a pastor in California, is one of our group. He's Congolese. He has a son who is a videographer. This is how the project, how this grassroots partnership gets put together. His son then, because he just graduated from film school, connected with young people on the ground who were empowered with their little handheld phones to go out and interview people that you will now see in this video.
Janine names 10 dead members of her family: mother, uncle, brothers and aunts. Ebola killed this baby's mother. There are hundreds of orphans like him. This Ebola outbreak began in August last year in the northeast of this vast country.
We're fighting one of the world's most dangerous viruses in one of the world's most dangerous areas.
The trauma in the DRC from Ebola is dire. So our Ebola Coalition asked people on the ground about their feelings and experiences.
My neighbor died, and so I think it's something real.
Ebola inexiste.
On doit croire que Ebola existe. Même si dans la communauté, il y a des gens qui pensent que Ebola n'existe pas.
Gonjwa lakini yeye ameendelea kuishi pale ndio mimi navifahamu sana.
It's 10 out of 10.
Se tipo sai a boca Ebola, Sina kwa kutoka Ebola leo hii juu ndio nafika mwisho.
Pengine wanapenda kusisi huku mkutano tuishe, alafu wanasukuma hiyo ugonjwa ili kuwa mawazo ya watu wengi.
Sincèrement, oui. Et ça l'était à la population, en partie kidogo ya population, kujute Ebola haiko, watu ndio wanatajirika.
We used to hug each other and to greet by shaking hands.
Ni kubadilika kama mtu alikuwa katika kundi ya Wakristo, tulianza ogopa kwenda katika makundi.
So Ebola is pushing me away from my community.
Aendelee, atonanake tena. Sipata mgeni tena kusema tunaogopa Ebola.
Anakuwa yatima, wengine anakuwa wajane, kuko probleme ya security.
Tusikuse maiti, tusisogelee mgonjwa mwenye kuna vomire. Ikuye Ebola ilikuye makilio atakatisipete na sana.
Ndio ibadilika ile juu chai, bwana bila chai mwote ilikuwa stope, bwana kupa kukunya mwele makopo, bana kopo mara mami ndistopa chai.
Mwezi kabisa. Na wakaniambia nao mkono mimi na nao. Na save access mwezi.
Kusema kwamba tuendelee basi kuomba Mungu na tuendelee pia kusikia mashauri maongozi wanaotuletea.
Thank you, Judy.
So you can see from this what people are really saying from their hearts. It's really, we thank very much the people who were brave enough to get these interviews, and thank you to the people who actually agreed to be interviewed. You saw some people weren't showing their face. There were many other interviews that we only saw an arm or something else because people do not want to be identified. So that's become a very major issue here too. So you saw many of the individual issues here. As a result of and this just happened, so this is very, very fresh, you know, happening now. So even though the cases are going down, these are still the issues that people are experiencing on the ground. So just to make some other quick points about this, you can tell from here how much the people feel disconnected from each other, because clearly, as was discussed here, not touching is really important. Even when I was in West Africa during Ebola, it's important people don't kiss, they don't hug, they don't shake, and there's a lot of pain that comes from that. So as a result, some of what we are doing in our training is operationalizing many of the theoretical issues. It's not just going to people and talking about what the issues are, what the problems are, but the training that we will be doing in the university, and by the way, you could see that this is a religious issue too, so we needed to add that into the holistic view. Besides all the other, the medical issues, the social, the economic issues, there's also a religious base here. And so a lot of the work that we're going to be doing is not just talking about how people should behave, how they shouldn't behave, they shouldn't touch people, don't touch the dead bodies, but creating what we're building on is a lot of experience in operationalizing by using exercises and activities that bring forth some of this community engagement. So there are activities where people hold different pens and they walk around in circles and they have to make sure that they don't drop the pens, and if they do, they stop and they pick up the pens and reconstitute the circle. So what does that really do? That creates a metaphor for community engagement and community helping one another. So this is the point of our intervention. Some didactics about what the virus is and some of dispelling the myths, but then activities that people can actually engage in, have fun doing, particularly children, and learn a lesson from without a lot of cognitive processing.
Thank you, Judy. You have 1 more minute if you wish to add something.
Oh, well, I think I've
You've done it?
Yeah.
Okay, great. Thank you very much, Judy. I would like to have Bibi, who is, like I mentioned before, she has her master's degree in public health, and she is a vital cog in the wheel.
So, Vicky,
for
why don't you
us.
come up here for a second?
Come. And part of the Ebola Coalition. And I'd like you to say a few words. 1 minute, please.
I mean, I'm just going to speak on Friends of Congo and how we have been helping the Ebola Coalition. So basically, Maurice and I have been using our network in Congo and here to help really involve the community, the diaspora, in the intervention that we're doing. So we wanted to do something that's really from the people to the people. So we have connected, Gordon here. So Gordon initially got into contact with Friends of Congo and Maurice, and then we were able to put them in contact with some of the people from the Nande communities, because initially they were facing greater resistance within the Nande community. So we were able to put them in contact with leaders from the Nande community, and then afterwards we were also able to put them in contact with other community in the ground. So in the end, we had a coalition that was formed of leaders in the diaspora and also NGOs and other communities on the ground. So we're working in collaboration like that. So that's what Friends of Congo has been done. We're really like connecting, bringing everybody together in order to make it really grassroots and community based.
Thank you. Okay.
Morris is not here yet, so he'll be here soon.
Well, stay here.
I would like to invite Dr. Solidza to say a few words. She was with the Permanent Mission of Georgia to the United Nations and contributed significantly to development of the universal health coverage that was included in the 2030 agenda.
And you can see, actually, this is the emblem of the umbrella, meaning that everyone should be covered by universal health coverage.
And she is, shall I say you're an expert at financing?
Innovative financing.
Innovative financing, okay. Very good.
Just, I think, important for people to know that Georgia was the president of Innovative Financing for Development, with France as the secretariat, and has just been passed on to Japan. And several major conferences happened in Georgia about the issue of innovative financing, because even though financing contributes to the problem, how is all of this going to happen? It needs to be paid for. And Tamara's also has a master's degree in public health, so she has a broad view of this issue.
Okay, tomorrow you have 3 minutes. Okay, and then we will have 20 minutes of Q&A. So you can respond to questions as well as everyone. Please.
So first of all, I'm just absolutely amazed with the presentation. Thank you so much. It was very educational for me, inspirational, and really ties well with all of the things that I've done for the past 20 years. So I do have public health background. I'm an MD. I'm also doing PhD in health policy management right now. So really, Ebola is something that I'm also very interested in, since my background is in infectious diseases, not in Ebola yet. So what I've done lately, I was a lead officer on Universal Health Coverage Political Declaration together with Thailand. I was really fortunate to be involved and negotiate the elements of this very important document, first time document actually, with member states, and most importantly, thank you to WHO. That was absolutely our right hand in the whole process. We got the first elements paper from the WHO, and we developed the declaration around the WHO suggestion. So why I'm saying the elements, because I was hearing all of the different things during the presentation, but it comes back to the education, how important that is when we're talking about eliminating something. So yes, vaccination is one thing, which is extremely, extremely important, but even with vaccination, you can't really do anything if you don't have all the prevention agenda in front of you, and that's where the education comes in, that's where your project goes. Because I want to say so many things, but it's just, to come back to the UHC, UHC is the universal health coverage. What we tried to achieve was we wanted to have the political declaration that the leaders will have it. First of all, they will commit to it. Secondly, they will take this document back home and translate it into the action plan. We didn't really prescribe in the declaration how they should do it because there is no size fits all. And we all know that, but we did include important elements which are the health system strengthening, like you mentioned, which is very important and ties to the Ebola case also. And with this political declaration, we also hope that the country will take more leadership and with other member states help into the health system strengthening. Another very important element, and it's only 11 pages long, and we do have health system strengthening, of course, we do have education. Education we even have in 3 paragraphs, and 1 paragraph stands alone only for educating not only the healthcare workers but also the communities, as we all talked about, is that it's extremely important, community engagement, healthcare worker education, and it's very important also that the healthcare workers that you are choosing, it's not the healthcare workers, but those are exactly people, because all those elements, like small ones, the religious, because we actually have that word in
Pastoral
too.
counselors.
We even have the to take into consideration culture and all these views of this when you are doing the education. Why I'm saying this also, that it's 11 pages long document that covers everything, but education is 3 times in the document. The emerging and re-emerging is there also separately, and health system strengthening. So those what we covered today are extremely, extremely important. So we really hope that this declaration will be inspirational, because we've seen some resolutions maybe not really into getting into the action as an action plan, and so really translated into the real tangible things, and we hope that this declaration will not be one of them. It will be the one that will be really done by 2030, that we are hoping to have all of the people have access to the essential health services at the time when they need it, and reaching farther behind and leaving no one behind. That's what the declaration is about.
If I could add, I think what's important for this, all of us, I feel like we're all part of this unified group of discussion that's really so inspirational, is to translate what some of these documents now are saying about what the governments have agreed that they're going to do. It's important that Tamara's describing the Universal Health Coverage Political Declaration, that Gordon mentioned before, the Sustainable Development Agenda 2030, that's so much part of WHO and Fatima's group has been so much a part of. These are the foundation that the governments have all agreed as a policy we're going to do. But now, as was said here, it's up to us as the grassroots NGO people to actually do it. To take all the words, the wonderful words of education, and this is what we're going to serve, and mental health and physical health, and do something with the people that they actually can take into themselves and feel better about. Like you said, I felt great when you announced what you were going to do. And that is a operationalized vision of what is in this document, I think. Isn't that really what happens
absolutely.
here?
Yeah.
Okay.
Stakeholders. Multi-stakeholder enrollment is the key.
Thank you, Tamara. Thank you very much. Okay. I'm going to give each person 1 minute for a closing statement. Fatima, Dr. Karna, Dr. Chow, Julie, and you. 1 minute.
1 minute.
And then we will have some Q&A from the floor. Okay?
Actually, can the closing statements be made from up front, just so we're
Right.
filming?
So I want you also just to take away 5 things about Ebola that I think are really important. And the first thing which I started with is that this is a really complex outbreak due to insecurity and due to the issue of community mistrust. So that's the first thing that I think is very important. So when you go back and you see that why has it taken over a year to get control of this thing, it's more complicated than it seems, I think, when you look at it from the outside. And the second thing that I think is very important is that the DRC is it's not just about Ebola. There's a lot of other things. We talked about the humanitarian crisis, other diseases, cholera, measles, malaria, non-communicable diseases. It's the second largest food crisis or malnutrition crisis in the world. That's really important to keep in mind. And the third thing is that this is something that we really rely on partnerships to deal with. It's not just one entity alone. It's not just the DRC government who's doing a fantastic job, but they can't do it alone. It's all of us together, the UN, governments, donors, NGOs, community leaders, academia, researchers, the whole group is coming together to deal with this. And then the fourth thing is preparedness. Preparedness for both the DRC and the neighboring countries. Preparedness in health systems, preparedness in surveillance and response, training of health workers, all of these aspects to prevent the outbreak from spreading. And then the last thing, which is this umbrella that you were talking about, is UHC and building capacities of countries. So universal health coverage, health system strengthening across the board, not just for Ebola, but for other health crises as well. So that's key, because if you have a strong health system, a functioning health system, we will not see these kinds of outbreaks at this scale anymore. So that's what I really hope you can take home with you today. Thanks.
Thank you very much. Dr. Choi?
Yeah, I mean, I guess I would reiterate the same things. This outbreak in DRC is definitely different than any of the other 20-some outbreaks that's happened since the virus has been discovered in 1976. I do also hope that, the idea of the survivors needing support, I think that's a tremendous need. Everyone who live in this area have been affected or touched some way by the outbreak, and especially with the survivors and dealing with the trauma of the loss and the infection. And then for other survivors for whom they're not sure if they're completely been free of the virus, again, added stress and difficulties going forward long after others have forgotten about the outbreak. And then I also would reiterate the importance of building strong public health systems, as part of the health structure, because again, with good surveillance, we're able to catch these outbreaks sooner.
Thank you very much, Dr. Choi. Dr. Anna.
So I think one thing that we maybe didn't talk about, but was that a lot of foreign responders, because of security concerns, are really restricted in their movements, and many of them are restricted to Goma or to certain sort of places that have been deemed sort of safe. And so really, as everyone nonetheless has emphasized, what we rely on for this epidemic to be over is the grassroots, is local health workers, local NGOs, local associations, and leaders. And so I think, again, I would just underline again the importance of community engagement, and maybe sort of make 4 points on that. One of which is that there needs to be a kind of whole of society approach. So one issue, I didn't get to talk about it, but I do research on the vaccine deployment in Equateur, and on the sort of the issues that people saw with it, and the concerns that they still have following the vaccination. And one of the issues is around communication around the vaccination, which was primarily directed at those within the ring and those who were getting the vaccination, and left sort of broader communities confused about what was actually happening and who should have access to the vaccine. So really an emphasis on a whole of society approach that attempts to integrate not only Ebola victims' families, but really just the broader community, and that would also recognize that communities are not homogenous, that really you need to pay attention to all of the different stakeholders or the different interest groups in communities. And then a third point would be really an attention to, on the part of responders, an attention to local stakes and to different ways of conceptualizing this epidemic, like the sort of economic lens, to not dismiss these at all, but to really pay attention to what it is that the ways that people are framing this epidemic and what their concerns are. And then finally, the most important is a commitment to utilizing pre-existing capacity into reinforcing that, so that local health structures and local health workers are really reinforced and supported, that efforts are made to bring treatment to where patients are, to maybe even consider training people in looking after patients at home, because there's a real culture of, there's the garde malade, the person who goes with a sick person, or in fact the people who go with a sick person in Congo, that you don't just hand over sick people to a hospital, you always accompany them. And so when Ebola treatment centers are really far away from communities, it's just an impossible amount of suffering to allow your sick relative to go that far away from you. Yeah, so again, just a real sort of emphasis on real community engagement that is not only about education, but is about asking people each step of the way, what are we doing wrong, what can we do better? And then on that point of survivors, that's something that I think that the diaspora could really connect with, is the Association Nationale des Vainqueurs d'Ebola, so the association for people who've survived Ebola, which is I think now nationwide, and it started in the Equateur outbreak, and that is a group of people who could really do with kind of support and connection.
Thank you very much. Thank you. Dr. Tamara.
I will make comments on the innovation financing, since I didn't get a chance to say about it. The innovation financing program will be a key role, not only in Ebola, but in general in 2030 agenda. 2030 agenda is around 17 goals. We all know this. Those are inspirational goals that we want to achieve it by in 10 years from now. But if we look, how much give it is, it's quite significant. That's $2.5 trillion a year. That if we multiply by 10, it's already almost $30 trillion. So we need to really find the innovative ways to fund the projects that we want to do within this 2030 agenda. And I will just very briefly tell you Georgia's example, because we had one of shining example of the innovative financing called Solidarity Fund. We established under Prime Minister's office in 2015, and Judy actually was with me in Georgia when we also conducted one of this Ministry of France. It's nothing has to do with that particular project, but because we studied that project, we then joined and became a president country of leading group on innovative financing. So what we did with the Solidarity Fund, we established under the government. The foundation usually is not associated with the government, but this unique structure really worked, and I tell you why. It's for two reasons. Number one, the government had already trust in the people, so we had built the system in the way that the government has trust in the people, so people were happy to invest in the foundation that was run by the government. But it was not really run by the government, it was actually paid by the government for the space, for the people that was employed and is employed still for the foundation. But then we had the executive board that was with the multi-stakeholder people, so NGO, civil society, we had private sector, and then we had also observers from the UN, actually World Bank, and two embassies, and we were choosing it year-wise. So what we did for the first year, we raised about $2.5 million, and it's size of the 4 million people. It's not a big country, so you can see that, and it was like mostly, we had 6 sources for the income. Out of the 6, only 1 was not voluntary. It's not really that we enforced, but it was banks with the ATM transaction with the wires. But the others, for example, it was voluntary submission. 50,000 employees, government as well as the private sector, signed up for the project, and they are still until today paying. So what we're doing with that money, we had goals. The first goal, we had to cover every children with cancer, and we will increase the age group, so it's until 23rd. So this is one of the, I don't want to go long, I know I don't have much time, but yeah.
Okay, thank you very much. Thank you. And Judy?
So I'll just emphasize 2 things. One is the importance, underlining of a holistic view of this issue, taking into account all the things that everyone has said in terms of medical, social, economic, and financial issues, and certainly psychological issues that are so important. And the last point is to really, by your being here, and by everyone here coming from different places and Washington, whatever, the bottom line is showing that you care. I have learned from being everywhere around the world in all different cultures, in Middle East cultures, Asian cultures, African cultures, that when you come with your heart to show people that you care, that makes a difference.
Okay, well, thank you very much. We're not done. We're going to give you all an opportunity to ask a few questions. We can do that for another 15 minutes. So we should be able to get to 3-4 questions or so. If you have one, there's no time to pause. Please, go ahead.
I have a question. Could you expand a bit more on how you raised the 2.5 million? And what were the actual, processes to get that money?
He's the prospective one.
Right. Raising money for, right, there you go. Awesome.
So we actually announced the project at the beginning, and the employees of the government or government structures or the private sectors, they signed up for the project. So monthly they were contributing to the project. So yeah, that's one of the ways. For the ATM transactions that I mentioned with the banks, we developed partnerships with them, so they were contributing. We also developed partnership with the airline companies, but it was on the solidarity and voluntary base. And transaction with the movie theaters, like tickets sales, every sale, every ticket was contributing to this. So that's how we ended up to have that.
Thank you. Yes, go ahead.
I have a question about the communication environment during this epidemic. During the West African epidemic, there was a lot of lack of coordination in all aspects of the response. And that was kind of published in the MOON report, LSHT and Harvard. But particularly in the area of communication. So how do you see, those of you who have been on the field, on the ground, how have you seen the improvement in communication from institutions to communities, particularly in the use of specific messaging around treatment? You know, there was a problematic issue with using the term Ebola treatment unit when a lot of the messaging was that Ebola has no treatment, at least in the West African epidemic. And along those lines, how has it been in terms of community engagement and the use of local media, particularly radio, for example, broadcast radio, in terms of galvanizing kind of community engagement? If you can, I don't know, say something about that.
I'm going to ask Dr. Alexander to speak up to that. But could you identify yourself?
My name is Carlos Chirinos, NYU. I did research during the Ebola epidemic in West Africa, and I kind of working with the role of arts, and particularly music and broadcast radio and community engagement.
Fantastic.
So if it's okay, I'll speak to the Equateur outbreak because I know more about it. And you're absolutely right that there was an initial sort of what everyone now recognizes as a huge mistake, that even in the Equateur outbreak, the initial messaging was don't catch Ebola because there is no cure, which then hugely hindered then the later attempts to get people to come to Ebola treatment centers and to get the vaccine. And there was also an issue of a lack of coordination in terms, for example, of getting community health workers who do the majority of sort of going out into communities and doing both the surveillance and also some of the risk communication, that they were being employed by different organizations, sometimes to do similar jobs but with different pay scales also. So coordination is a huge, huge issue. And then to your question of messaging, I'd like to again emphasize local capacity, because Bandaka is, and Equateur is a region where there aren't a huge number of higher education institutions. There is, most people are subsistence farmers, and so there was a kind of assumption that we have to bring in experts from everywhere, and yet there always is capacity. And I did interviews with local social scientists who had studied sociology or psychology at university years ago, and who themselves were doing research on messaging. And for example, one of them was studying the fact that the posters that have these kind of cartoons that show like how the symptoms of Ebola, how not to catch Ebola, were being completely misunderstood by people who don't have such a visual culture in terms of communication, and that it was far more effective to work with their oral modes of communication through radio, but also through public announcements by leaders and through word of mouth or the radio trottoir. So that, yeah, it's again an emphasis on local capacity and on using the types of communication that are going to be the most effective in the particular context that you're in.
Okay. Nelson?
Yeah. I had a general question. I was wondering to what degree the presidential transition from Kabila to Tshisekedi has impacted sort of the national efforts around Ebola. If there's been any changes, or if even just the transition itself has had an effect.
Yeah, I can address that fairly quickly. It's still, one thing is Tshisekedi, it's fairly a new government, but he's made it one of his, I shouldn't say one of, but his major presidential priority is the Ebola outbreak. And having said that, there's some people that were involved in the outbreak under the previous administration that are still involved in the outbreak. So there's a good handover as well, and there's quite a few experts that have been working on the outbreak in the past that are still on hand. So I think we're seeing a smooth transition so far. We're quite hopeful that we'll continue to see that, and you know, the previous and current administrations have been fully on board with trying to see us get to zero. So so far so good.
Yes, please go ahead.
Hi, this question is for Judy. So I actually started working on a holistic wellness program for the city of Newark. So like the Black population is dying at a rate literally double that of what white and Hispanics are dying combined. In that journey, somehow I started working with the school in Liberia, and I know that Ebola was an issue there. So just hearing about you guys' program to go to Benin and to teach them, where could I also, I guess, find those type of resources? So like for instance, the same training that you're going to be teaching over there, like is there information that I could tap to here in America to have access to?
Well, I'm glad you said that. We're very happy to share with you the packages and the training modules and the work that we're doing, and delighted to spread it to other countries. So for sure, let's be in touch, and that's fantastic. That's the value of our being here. So great, thank you.
Thank you.
It's in development.
Yeah, so, well, the pilot, for the most part, is done. I'm just in talks with the teacher to make sure she knows what to do. But I did it, so it's for the kids. So I did a comic on how flies carry disease, a song for like how you wash your hands, and that's like a classroom activity. And also I did a video on menstruation. Menstrupedia let me use their material to teach them about menstruation.
Great, thank you. Love to share.
Very good. Very good.
Thank you. Stay around.
Vivi?
My question is for like the different organization to the diaspora. So how do you guys make yourself accessible to the diaspora that has family on the ground? Like how can they connect with you guys to get information if they need to go back and help their families, loved ones get you know, like real information, facts on the response? Like how do you guys connect with the diaspora?
You probably would be talking about the daily reports, situation
No,
reports?
just because not everybody follows the daily report.
I know,
right? So
I know.
like does WHO have a point person in New York that people can, contact if they have a question?
Me.
The CDC have a person that they can contact if they have a specific question. Does anthropological have, that's what I mean.
Okay,
Yeah, so as you know, we have a website, cdc.gov /Ebola, that has multiple pages on Ebola for various different audiences. I think if you're looking for a point person, that would be me. We also do have a communications group. We also have a communications group, and we've been working with the Congolese diaspora back in Atlanta, and we've had a couple of meetings with them, as well as some teleconferences as well. But yeah, if there are any needs, please feel free to contact me.
Yeah, I mean, similar, we have a lot of information online, and the hope is that you'll get everything you need, both French and English, on specific questions related to Ebola, specifically since we're talking about that. And if you can't find something, you come to our office. The good thing about WHO New York is we're very small, so it's easy to find us. So there's me and there's another colleague who does communication, so you can talk to either one of us.
I saw another hand, yes.
Hi, I just want to say thank you so much to all the panelists for sharing all that information. It's been really great to hear. My question is actually for Fatima. Thank you so much for talking about the complexities of everything that's happening. Oftentimes what we see in humanitarian settings is that a lot of the resources and capacities are pushed towards the new emergency that's coming up. And as you said, or as someone else said, that then propagates or aggravates other situations happening, perhaps with nutrition or other related aspects to the health system or other systems. So in working in humanitarian crises, how do we ensure that a whole systems approach is taken to ensure that the linkages between the emergency crisis and those other aspects, cholera, nutrition, whatever it may be, don't fall to the backside when focusing on a new emergency?
Well, regarding that, we have UN country teams in place that are in all countries where the UN is functioning, and then specifically for humanitarian emergencies, they focus on humanitarian emergencies. There's a humanitarian coordinator that is in charge of coordinating all humanitarian activities, so not just health, but also looking at refugees, food security, protection, sexual reproductive health, all the whole gamut of humanitarian issues. So, and for Ebola, for instance, we talked about the SRP. For all humanitarian crises, we have something called a humanitarian response plan. So that looks at the full set of humanitarian needs in all sectors. And then if you want to look at further than humanitarian issues, but development issues as well, we're trying to, which is a little complicated because in the UN system and also with donors as well, you look at humanitarian issues in one kind of box and development in the other, and we're trying to link those things, and that's something that the UN is working on now to bring the linkages between humanitarian and development work. WHO does that very much when we work on the ground, because even in this Ebola response, when we're looking at training doctors, it's not just only for Ebola, this is for the future, so we're trying to build capacities with, in local health systems, with local health providers that will last beyond the Ebola outbreak and for other issues as well. So that's just one example of how we're trying to link it. So we're very mindful of the issue. It's not always perfect, but we're certainly aware of, these different dynamics, and we're trying to address it as well as we can.
Thank you very much. Any other question? All right. Well, I would like to thank, first of all, Nelson for arranging this, and thanks to the Baseless Theatre for accommodating this panel discussion. And of course, this is the most wonderful panel imaginable, most informed, most knowledgeable, and experienced in different areas. Right, I'm getting to be like you, Judy. I'm getting passionate and excited. I'm very happy for all your contributions, and I'm really hoping that we can rely on all of you again as a resource for information and for advice, for ideas as we move forward, for we are moving forward. and to rely on you not only for information, but for perhaps even active support as we move forward. And you all have the knowledge, you have the experience, you've been there, you know everything about psychosocial support, community engagement. That is what we are about, and we will need your input along the way. Thank you so very much. I want to thank Bibi and everyone who's here. It's not as large an audience as we would have wanted. And I should tell you, one of the very big attractions today, maybe I shouldn't call it attraction, but there will be a meeting at 131st Street and Malcolm X Boulevard regarding issues pertaining to the African Union. And I know that a lot of people who would normally be here are there. The ambassador of the African Union in Washington, D.C. is there, and there are a lot of problems with the African Union and with the embassy in Washington. And everyone, there was a sign-in went out, and there were almost 100,000 signatures that were people who signed up in just 1 week about something that happened with the AU. And so that has attracted a lot of people. Anyway, thank you all for coming, and I want to thank you.